Now I'm introducing Jay Setti, who will introduce our speaker for this evening.
Thank you, Sam. We have a great topic, very useful topic, and a great speaker this evening, Dr. Magodia. Dr. Magodia graduated from Temple University School of Podiatrics and Medicine, and later she completed her 4 years work at Temple University in foot and ankle surgical residency. She also served as the chief resident at Temple University. Dr. Magodia has practiced at Lawrenceville and East Brunswick. Dr. Magodia.
Right. No worries. First and foremost, thank you so much for having me today. And thank you for inviting me here and coordinating all of this. Today, I'm actually going to talk about diabetes, diabetic shoes, but also some of the signs and symptoms that we can identify on ourselves that sort of tell us when should we go see a podiatrist. Majority of my patients, when they come in when something is wrong. But there are several signs before we even get to that point where it's a good idea to come in and promote more of sort of a preventative care. Next slide, please. I know. This is just a little bit of my own journey. I went to Rutgers University in New Brunswick. I went to the School of Arts and Sciences. I did my pre-medical studies there. I also completed a French major there. Next. And then I went to Temple University School of Podiatric Medicine, which is a 4-year program in Philadelphia. Next. And then I completed a 4-year surgical residency at Temple University Hospital with 2 focuses in foot and ankle trauma and also diabetic limb salvage. There's a significantly large portion of diabetic individuals in Philadelphia, and unfortunately, we see a lot of pathology. So it helps us conduct a lot of research on how we can prevent amputations and also help prevent limb loss. And I currently practice in Lawrenceville, also have another office in Florence, and every other week I go to a recreational senior center in Atlantic City where I do foot exams and also, once again, do more diabetic risk assessment and care. Next. All right, so when it comes to diabetes, it's good to have a general overview, and then we'll get sort of more into focus with just the foot health portion. So when you have diabetes, you're dealing with a state where you have more glucose in your blood than should be there. Normal blood glucose, it's okay to have some molecules here and there, but if you have high blood glucose, that is when you are in a diabetic state. So glucose, we actually need it. It comes in the form of the food that we eat as fuel. When the body is unable to use that glucose positively, that is when we get diabetes. For example, the main organ that is at work here is the pancreas, and it does a couple things. It either does not produce enough insulin, it does not produce proper insulin that is actually functional, or it does not produce any insulin. So what does that look like? Next slide. So type 1 diabetes is the less common one. Typically, you can see that in juvenile diabetes or insulin-dependent diabetes. This is where your own body attacks the insulin cells that are being created in the pancreas. So therefore, they're not able to do their job properly. Here's where you need to inject insulin so that the body can actually use the glucose that it is getting from the food. Now, if glucose stays in the bloodstream, that is when you get symptoms of being hungry, tired, increased thirst, frequent urination, or even weight loss. So a good rule to keep in mind is if you feel either of these things happening, it's good to talk to your primary care provider. And certainly if a combination occurs, that's incredibly important. Next, thank you. So this is just a quick schematic, once again showing a healthy individual where you have insulin being produced and being targeted to the cells, and then you have a diabetic individual where you see all of that glucose accumulating. Next slide. So type 2 diabetes, this is the one that we encounter the most. This is the most common type. When people think of diabetes, it's really type 2 diabetes that they are having in mind. It is a non-insulin dependent diabetes. Here is where insulin is being produced, but there's not enough of it, or even if it is being produced, it's not working very well, or the liver is producing too much glucose. You can get fatigue, changes in your vision, and this is what I tend to see a lot more of: infections and delayed healing, which starts to slowly come into my territory. And here is just a quick example of all three of them. Next slide. Now, risk factors to be aware of. Family history is a big one. Unfortunately, that is one that we cannot control. However, if we have a genetic predisposition, it's good to keep in mind because there are steps that you can take beforehand. Being overweight, having high blood pressure, being over a certain age, although now with people being a lot more sedentary and having increased processed foods or increased takeout, we're seeing diabetes happen in people that are younger and younger, including type 2 diabetes in children. High cholesterol, history of any kind of gestational diabetes while pregnant, cardiovascular disease, a more sedentary and inactive lifestyle, and smoking. And again, the two from this chart, two things that I see the most are the slow healing and numbness in the hands and the feet. Diabetes ends up affecting our vascular system and can change the circulation in the body and reduce it. And therefore, you don't get the adequate blood supply you need when you heal a cut. So somebody who is diabetic can step on something, and instead of the skin nicely healing itself quickly, it turns into a wound. Numbness in the hands and feet is also very common. The nerves, you can think of them kind of like a tree branch. So the nerves all the way at the very end, they start getting affected by the glucose too. And you can get burning, numbness, tingling, and certainly that can affect how you walk. That can also affect stability. So how does diabetes tie into foot health? Next slide. Next. So diabetes and foot health are actually very intricately related. Many of the sequelae of having diabetes translates into symptoms in the feet, and a lot of them can be caught early and monitored and managed. And unfortunately, many of these, if they are neglected, can lead to amputations or even limb loss. Next slide. Thank you. So what people don't realize, and I think it's good to highlight, is sometimes some of the most rudimentary and common foot problems can actually be signs or precursors to something more that needs to be evaluated. For example, athlete's foot. Athlete's foot can often look just like dry skin. So many people say, I've got dry skin. I put on lotion, doesn't go away, not realizing that it actually might be because of a fungal cause. Athlete's foot, fungal infection of nails, corns, and calluses, they can pose a risk because they often occur at pressure point areas. And if left untreated, as we're walking on them, they can actually break down the skin and cause an underlying wound that may not be visible at all. And certainly if there is a lack of sensation or diminished sensation in the feet, then you might not even have any pain unless it gets really, really progressed. Having dry, cracked skin can cause fissures, and these fissures are at increased risk of infection because it can trap moisture, blisters, foot ulcers, hammer toes, and bunions. So many people have them, but if you're not wearing the right footwear, it can cause rubbing, and these can also lead to wounds. So it is important to seek medical care when you even have any of this, just so you can be reassured that, you know what? I know you have your hammer toe, I know you have your bunion, but you don't have any corns, calluses, no pain, you're fine. So it's good to have this evaluated, especially if you're a diabetic. And at some point, even if you're not, because you may not know that there could be something wrong with your feet until you actually have them examined. And certainly it's important to have them examined frequently, because if you don't have that great sensation in your feet, you could easily miss a puncture wound where you might have stepped on something, or any small open sores or anything like that in the feet. Next. So this leads me to something that has been around for a while, but I think has really gotten streamlined well in the past few years, which are diabetic shoes. Diabetic shoes are there for protection. They're there for comfort and support. And what differentiates them from a standard heavy orthopedic shoe is that they are made of a lightweight material. They have a microfiber lining, so they're actually going to prevent irritation, can provide pain relief if you have sensitive feet. We have plenty of diabetic shoes that we go through for our office, and they get to me first, and I always feel the inside. And it is so much softer than a traditional shoe, and is much better from preventing skin, especially near the bony areas of the ankle and places like that, from breaking down. You can also get extra depth, which means that you are walking with more sureness on the ground, and there is more even distribution of plantar pressure. That just means pressure underneath your feet when you're walking. If you do have hammer toes, bunions, things like that, which are just basically, hammer toes when a toe, instead of standing straight, tends to curve upwards. A bunion is when the big toe starts moving inwards. If you have those, then diabetic shoes tend to be a little wider near the toes and provide more room, so that there's less rubbing and cause for a callus or a corn to come up. And there's also a strong supportive heel. So if your arch is collapsing as you walk, there is something there to help counter it and give you more support, which ends up giving your knees more support, your hips more support, and your lower back. Next. Thank you. And here you can see the breakdown of a diabetic shoe. You can see that there are many layers and components that actually help absorb shock from the ground. So over time, sometimes you might notice that the nice pad of fat that we have underneath our feet can thin out, and some of the bones can feel a little bit more prominent. So having that extra layer to just absorb shock every time we put our foot on the ground helps us with walking, and helps us be a little bit more dynamic and have more protection as we walk. So you can see that there's an extra foam padding, there's some protective lining, and ultimately it just helps create a bit more of a flow in your stride as well, and gives you that extra help. This is how they used to look like. Sometimes you'll still find these out and about. Unless you've had an amputation or that kind of a situation, typically the traditional diabetic shoe is not something that's always used. Now we have diabetic shoes that look just like regular sneakers. There are hiking shoes. You can wear shoes without shoelaces, slip-on, so that you can have them custom and tailored to the lifestyle that you have. So if you are somebody that's more active, that enjoys going on walks, you can have a more dynamic and breathable shoe that does all of the other functions, but is also more like a normal sneaker. So they're designed to be comfortable. The brand that we use in my office is Anodyne. They have kind of like 50 pairs of, different shoes and styles. So I certainly recommend looking into this if you feel like you qualify. So what is the process to get a diabetic shoe? First and foremost, you want to get evaluated by a podiatrist. There are 4 things we do every time we do a diabetic foot exam. We check your circulation system. The same way that if you put your fingers up to your pulse in your neck, you can feel your pulse. There are pulses in our feet that we check, and that gives us an immediate idea of where your circulation level stands. And if we're not able to feel them, then we go into more testing and we're able to get a baseline. So that is important. We also do a dermatological exam, check in between the toes, make sure the skin is healthy, make sure that there's no signs of infection or fungus or dryness that could cause infection. We check the strength of the muscles and all the different compartments of the leg and the feet. We also check for neurological symptoms. We make sure that we're identifying that all of the nerve components that we need in our feet are firing properly and you're able to sense everything. That is done every single time you go see a podiatrist. And then the next thing you need is note from your primary care doctor. We work with primary care doctors and endocrinologists because now insurance companies like to have proof that you are diabetic. So that is how we work with them, and that's how we're able to get the shoes faster and get the measurement done quickly. There are many insurances that are in network where you're able to get diabetic shoes without any out-of-pocket cost. It's important to talk to your podiatrist and see what insurance you have, and you might be able to just get a pair of shoes every single year without any additional extra cost. And if for any reason it's out of network, a prescription at a medical equipment store can also go a long way. So again, there's several different options if this is something that you need, and I'm happy to explain it to you even further. So according to the American Diabetes Association, when it comes to standard of care, at the very minimum, you should be having a diabetic risk podiatric evaluation for your feet at least once a year. How much more frequently it should be done, that will be determined by your podiatrist. Based off of the signs and symptoms in your feet, every year you should be having them checked out. Now, based off the blood glucose levels, what type of feet you have, and certain exam findings, you may have to be seen every month, or you may have to be seen once a quarter. But these are all things that are determined once you have your diabetic foot exam, especially because certain calluses and corns in certain areas can be indicative of even possible ulcers in the future. So it's good to have these things monitored, and at the very, very least, it should be once a year. And also, when you go see a primary care doctor, that's a good occasion too to make sure to show them your feet. It's not always that they say, okay, go ahead, take off your shoes. A lot of primary care doctors now are very comprehensive and will also do a diabetic foot exam, but it's good to take that matter in your own hands. And while you're there, just take off your shoes and socks and say, do my feet look healthy? Do I need to go see a podiatrist? And they will guide you accordingly. Now, if you don't have diabetes, but you have a history of smoking, you have very, very similar risk factors to somebody who is diabetic. So you need to be seen in the same way that a diabetic patient would need to be seen as well. So even that is something where you need to be monitored every few months or a couple times a year, and make sure that anything is being caught beforehand. Sometimes I have had situations in my office where somebody will come to me, and I've known them for every few months I see them. And one day they come to me and one toe just happens to be a little bit more blue than the others. Doesn't hurt them, nothing. Send them for an ultrasound, there's a blood clot. And because it got identified early, you can go get treatment at the hospital, get put on blood thinners, and you are fine. However, the more you kind of leave that to yourself, I've also had the unfortunate experience of somebody losing that toe, or ultimately even the leg. So it's great to be routinely seen for these things, because there's so much that you can catch beforehand that now it's becoming more and more rare that I have to tell a patient some really bad news, which is great. Next. So I wanted to go over a little bit of what exactly is podiatry, because there's many things that are sort of attached to podiatry that contribute to our general health and well-being as well. And podiatry is anything in the foot and ankle, structures of the leg, the musculature, that we cover all of that. There's a medical component to it and a surgical component. We see acute conditions, which would be something like somebody falling or stubbing their toe, having a fracture, or chronic, which is arthritis. I see all different types of arthritis, from osteo to rheumatoid to gout, and it is helpful monitoring those closely as well. Next. So when it comes to common conditions that I see, heel pain is a big one, ingrown toenails, any kind of tendonitis, sprains, ulcers, fractures, infection, and of course, diabetic care. The major reason that people come to see me, and it's always on my form, is my foot hurts. That is the standard phrase, and there could be many reasons why that could occur. Next slide. For example, some of the most common causes of foot pain could be any kind of heel pain. Now, heel pain we use as a sort of umbrella term, but that could mean your Achilles tendon in the back of your heel. That could mean plantar fasciitis, which is a ligament that gets pulled in the bottom of the heel. You could have a stress fracture and not realize, especially if you have osteoporosis or osteopenia where the bone is weakened. Ingrown toenails can often turn into big infections if they are self-treated or if they are not treated. I once had a patient who had numbness in their feet and the ingrown toenail had dug so in that it was actually touching the bone underneath the toe. So these are all reasons why it's good to be seen. Corns and calluses are big reasons. Bunions, sometimes bunions get arthritic in that big toe joint. So that's important, especially if you have a bunion that's arthritic, you don't want surgery, and you can get orthotics, you can get injection therapy, you can do things that can continue to keep you active and moving like you typically would. Next slide. So it's important for me to highlight toenail conditions because sometimes what can seem very common or quote unquote your version of normal can be completely different to me. These are all things that I have seen in my office in different variations. Ingrown toenails, like I said, it can turn into a massive wound if left untreated. Now you can see all the toenails on the right, which half of these are due to a rudimentary toenail fungus. The other half are just from wear and tear and damage and changes in circulation. And none of these technically would harm you, but it's the ones on the bottom left that are concerning. That is melanoma and that is skin cancer. And every now and then somebody walks into my office with a slightly darkened toenail, thinking it was maybe fungus, was told, oh, if I apply Vicks Vapor Rub or something on it, it'll go away. But really, it's an underlying melanoma. So if it looks strange, let your doctor tell you to apply the Vicks Vapor Rub or do something like that and do a little biopsy. Don't self-diagnose. Don't go based off the internet. And this is something that's extremely treatable if found early and pretty rough if found late. So since it is pretty preventable, if you see any kind of strange discoloration on your toenails, always have them checked out because it could be hiding something a little sinister, which we can always find earlier too. Next slide. So skin conditions to keep in mind. Plantar warts are very common, especially if you use any kind of a pool or you walk around barefoot or when traveling, went to a hotel, happen to be barefoot. If they're contagious, they can stay on surfaces. They're also important to be evaluated because sometimes you don't even realize you have a plantar wart. I have patients who come in thinking for years that they had a callus on their foot. It gets too painful, so they come in, and when I actually do my exam, I find out it's been a wart this entire time. And sometimes some warts do look like basal or squamous cell carcinoma, which are just localized forms of skin cancer. So again, if you think something is a wart, I know over the counter they have corn removers, wart removers. I would not trust any of that. I would first make sure you have it evaluated so you can see the distinction. Again, even with any kind of itching, cracked skin, dry, flaky skin, blisters, all of that could be a fungal infection and it can present in any of those ways. So it's good to know so you can get started on the right treatment. For example, on the picture in the bottom left, you can see that you have something called a hot spot. That's usually a spot where when you are walking, that area is hitting the ground more than anything else. Over time, that can develop a callus. If that callus is left untreated, it eventually can cut into the skin and become a wound. So getting things observed right at the hot spot point, getting diabetic shoes, getting orthotics, making sure that you have enough cushioning will prevent even a callus and will certainly prevent a wound. Next. Heel pain, that's one of the most common causes of why people walk into my office. And the reason why I really want to highlight this is because this is very treatable. If you're somebody who enjoys going on a daily walk and find that you are now experiencing pain at the bottom of the heel or behind the heel, just know that there are treatment options available. Physical therapy helps, medication helps, there are stretching exercises, there are splints and braces. But one of the biggest reasons to have heel pain evaluated and get an x-ray taken is so that you don't miss a stress fracture. Sometimes just from overwalking one day or landing on a step in an incorrect manner, you may have a small crack in your heel and you may not even realize. So to prevent any worsening, I would treat any small pain like that as something that should be evaluated. Next, please. Rheumatoid arthritis. I have found so many cases of rheumatoid arthritis purely from foot pain, where it's sort of worked in a backwards scenario where instead of a rheumatologist referring a foot pain patient to me, it's become the opposite. I'll have somebody that comes in with heel pain or feels like there's some tightness in their feet, some nerve pain, getting random rashes or nodules, and I will order a panel, check for the rheumatoid factor, and then we find out that they actually have rheumatoid arthritis. Rheumatoid arthritis is different from osteoarthritis, which is the regular arthritis that we think of. Regular arthritis is bone on bone when the cartilage thins out or even starts to go away. Rheumatoid arthritis is inflammatory. So it's again one of those things where your body is sort of attacking you. So it requires actual medicine, requires treatment, and requires observation. We've had to remove nodules like this in the operating room. Sometimes the arthritis requires steroid injections. So again, just standard foot pain could actually mean that you have something going on in your entire body. It's just that the foot is being symptomatic. So good reason to go check it out, then wait for it to get better. Next slide. All right, so I've always found this to be pretty interesting how some of the diseases and conditions that you see up on the slides, such as obesity, diabetes, arthritis, hypertension, high cholesterol, heart disease, they all can mimic the symptoms you see on the right. So one could lead to the other and vice versa. You may not know you have diabetes. You may not know you have arthritis. You may not know you have poor circulation or even heart disease. There are signs in our feet that we can immediately determine that one of these might be a risk factor. And it could be something as simple as dry skin, hard skin, dry toenails, discolored toenails, an odor, any sharp burning pain, tenderness, numbness, open sores, ulcers, or pain in your calves. Pain in your calves and the back of the legs is an important thing to go over because that is one of the earlier signs of poor blood circulation. You could be lucky and it just could be a tight muscle, but again, why risk it? It's good to go get your legs evaluated via an ultrasound. All vascular doctors do that. Many cardiology offices have that too. And sometimes, unless you say to them, "Oh, my legs have also been hurting," they just might not know. But those tools are all available for you to prevent anything worse. Next slide. And one more. Perfect. I always like to bring up pediatrics because if you're around family, it's good to just sometimes know even signs and symptoms for just young kids. And because kids don't actually always tell us what's going on, so you have to read body languages and cues. So I always like to bring this up in my lectures because you just never know when you're surrounded by a child and end up seeing something where you may need to tell their parent that they need to maybe go see a podiatrist. For example, if they're with peers or with siblings and they're not able to keep up, if they used to enjoy doing an activity like maybe playing soccer or going on the trampoline and now they don't want to do that anymore, they hide their feet or are shuffling their feet and trying not to show them to you. If they're tripping or falling or even just complaining of pain, these are good things to keep in mind for those moments when you're surrounded by family and you notice some of these signs and symptoms. Next, please. And also to just keep in mind, we also treat sports injuries. So I see many people from very competitive pickleball tournaments. I see people from competitive ping pong tournaments, somebody that spent a long time on a golf course. You could develop tendonitis, ingrown toenails, even a dislocated toe. So if you play recreational sports, something to keep in mind. Next, please. And I also want to highlight surgery. Many podiatrists now are at least 3 to 4 years trained surgically, and many even do fellowships in specific things. So if you've been following a podiatrist for a very long time, especially one who also does surgery, that's great because they know your feet, they know you, they know how you walk, they know what lifestyle you lead. And it's a great thing to keep in mind and keep everything in the same office because your feet are attached to the rest of your body. So I've certainly referred out if I feel like foot pain has been affecting the knee and the hip. I have orthopedic surgeons that we work with. I have sports medicine doctors that we work with, but it's good to keep in mind. And if you consistently follow up and are getting evaluated, so many of these things can be done before it really needs to be done or done at the right time. And you're able to get back to the functionality that you need to be at. Next, please. So rule of thumb, I always tell people reach out and go see a podiatrist if it hurts, it looks strange, smells strange, or feels strange. It does not need to be any more involved or complicated than that. And for all you know, you might be saving a toe, a foot, or at the very least, getting back to an activity level that you didn't realize that you could get back to. And that makes a huge difference. All right, does anybody have any questions? Yes. That's a great question. So the question that was asked is how correctable is the hammer toe issue? So there are different levels. If you have a flexible hammer toe, meaning when you are at rest, it curls up. But if I were to take it and straighten it out, it straightens out when you hold it. That is a very simple surgery that usually requires maybe half an hour in the surgical center. You're walking in a shoe. There may not be any pins or anything put in there. It's a quick same-day procedure. However, if it's a very rigid hammer toe and there is tendon deformity below it, it's a little bit more involved and you would still be walking that day, but you would have a pin in your toe for about 4 to 6 weeks that would come out in the office. So you just have to be a little bit careful with how you shower and things like that. Anybody else? Yes? Yes. Sure, yes. So when I was talking about numbness and tingling and burning in the feet, those symptoms are all symptoms that are part of neuropathy. So neuropathy is essentially when nerves in our feet, which tell us how we're feeling, don't work properly. And that can be a whole host of symptoms. So if you randomly have burning in your feet, it could be neuropathy. If you've lost sensation in your feet, it could be neuropathy. The best way to really check is going to the podiatrist, and we have exams that we do where we can differentiate with whether it's a diabetic neuropathy. You don't have to be diabetic to get neuropathy. There are many types of neuropathy outside of diabetes. And then ultimately, even getting a referral to a neurologist to physically check the circulation of the nerves and the sensation for a formal diagnosis. Does that answer your question? Okay. Anybody else? Yes?
You mentioned osteopenia. Can
Mhm.
you further tell me what that means?
Sure, yes. So I mentioned osteoporosis and osteopenia. These are conditions in which you have weakness of the bone, and there can be hormonal reasons and chemical reasons as to why that is occurring. Osteopenia, I often see in x-rays. For example, if somebody comes in complaining about foot pain and I decided to take x-rays to see what's going on, usually healthy bone is nice and bright and white on the x-rays. If it looks faded, if it looks a little gray, that means it's lost a lot of its mineral substance and density and also some of its strength. So osteopenia is just the formal term for weakening in the bone. And oftentimes I'll see that and refer them to the primary care provider to get their vitamin D levels and everything checked, because they could actually have osteoporosis, which is the condition where you formally have a hormone imbalance and need medication to treat. You can, yes, you can see something abnormal for sure, yes. Oh, sure. So I think what you mean is the new sort of Lapiplasty. Yes, okay. So there are over 100 ways to correct a bunion, technically. We learn about all of them in school, and based off who we train under, we typically learn many types, and then we pick the type that works best for us and our hands, and we do that. We also pick the type of bunion surgery based off of how severe the bunion is. So one bunion surgery means you're walking sooner, and one means you're off your feet for about 2 months. The Lapiplasty is something that has come up that is a more minimally invasive way to correct a bunion. It still is a lot of hardware, and based off of how it's done, all under an x-ray machine, you can start walking earlier. So depending on certain lifestyle situations, depending on whether you live in an upstairs type of situation, etc., you can certainly consider that. Not everybody does it. There's a specific course that you have to take. It was not something that was taught in schools years ago or in surgery centers. Now it's something that's becoming more and more common. Not all bunions, however, need it. So it is very important to be evaluated, because you may not actually need the Lapiplasty, but it is certainly a good option if your bunion falls within those parameters.
Sorry, but this is something we're looking at in general. For an infant or newborn cell, a piece of cell tissue is taken out. Is there any AI predictability in examining that cell that will show some kind of genetic marker that might indicate a future condition?
So in general, or in the world of
In
podiatry?
terms of, let's say, this particular area of podiatry.
So it can, there is a world in which it can possibly predict things like clubfoot or certain types of very specific neurological related foot deformities. Very few of these are genetic. Many of them are due to positional issues in the womb and things like that, especially clubfoot. But at the same time, some of them that can be genetic, especially if you have certain types of body tremors or neurological diseases like Parkinson's that have hyperactivity in the feet and could result in certain behaviors in the feet. I certainly think AI at some point will be able to identify those markers. Yeah.
Yeah, rheumatoid arthritis, it's a autoimmune disease and the drug treatment is not very promising right now. Do you see in your practice quite a prevalence of rheumatoid arthritis because of the foot?
Yes, I do see quite a high prevalence of rheumatoid arthritis, and that's why it used to not always be part of my slides, but now because I see so much of it, it's something I always like to mention. And you're right, they have biologic medication where you can go for infusions and it can help with joint pain and can help with flare-ups. I've had some patients that have had those administered through a rheumatologist and have found success, and have some patients who have not. So really they see me to make sure that their joint health is maintained, that there's no breakdown of the joint. Sometimes the arthritis gets so stiff that they actually end up needing arthrodesis or fusion procedures done so that they can have a non-painful limb and can walk normally. So there are things that we do to help mitigate some of those symptoms, and also things that we can catch signs of early on, but really it's monitoring all of your joints that could potentially continue to worsen. And if you have a rheumatoid nodule, which is sort of like this lump that can show up on your hands and even on your feet or on your toes, if it's something where you can't get a shoe on, then you're better off getting that nodule removed so you can get the shoe on and walk normally. So we also look for all of that. Yes. Yeah.
First of all, thank you for an excellent program. My question relates to osteoporosis in men. I thought it was primarily a gender-related, is it a disorder or disease?
So I think that it is a bit more of a disease just because of its metabolic origins of why osteoporosis occurs. It is more prevalent in women. I have more female patients who have osteoporosis than I do have male patients who have osteoporosis. But that being said, you can get it even if you are not female. So I think it's good that if you're experiencing any kind of weakness or any pain in random bones or aching, it's good to just have a scan done and see your doctor so that you're not missing something and you're not unnecessarily getting that hip fracture that could have been prevented. Anybody else? Well, thank you so much for having me.